thank the organizers for this very honorable invitation. It's a great pleasure for me to contribute with this video today. So, you saw my university already. So this is the case of a female 44-year-old with a large stone in the lower pole of a horseshoe kidney on the left side. It is our routine practice to have a CT scan before, and we can see the contrast and without contrast CT scan. We see the stone there in the lower pole on the left in a horseshoe kidney. These are the 3D reconstruction images. We usually do this to have a better overview of what we're going to encounter, better see the stone, and have an idea of the anatomy of the territory that we're going to get in. So it is our policy in RIRS to have pre-stented the patient. So the patient was pre-stented. This is our equipment. I'm going to analyze further during the video. We start with the normal procedure with the cystoscopy, remove the WJ stent that we have inside, and after that we insert a ureteral catheter. This is a Tiger from Bart ureteral catheter in the left orifice. You see on the right side the C-arm images. We perform an antegrade pielogram to see the anatomy better, and through the ureteral catheter we insert a Terumo guide wire 0.035 up to the kidney as usual. Removal of the catheter, insertion of ureteral access sheath. In this case, we used the flexor parallel rapidly release ureteral access sheath, which is progressed slowly and meticulously up to the kidney. This type of access sheath give us the opportunity, as we all know, to leave the guide wire in situ after removing the internal part of the sheath as a safety guide wire. And now we get into the access sheath with our single-use flexible ureteral renoscope. We use the WeScope new generation here. Through the sheath up to the renal pelvis, a little bit retraction of the access sheath to have a better maneuverability, insertion of the scope. We flash the kidney to get a better image. We use the endoflow pump with the Traxer tubes to clean the kidney and have a better digital image, and we perform renoscopy, trying to locate the stone. Down on in the middle and down, we will now see the place where the stone is. These are actually two stones. It's a big load, and normally in a lower pole, we would relocate the stone, but in this case, since the stone is rather big, and we are using a single use instrument, we have decided to break the stone in situ. The instrument gives the opportunity to make this deflection into this rather steep angle, insertion of a 2.72 micrometer Holmu laser fiber. We're using the system of Dornier, 35 watts, and the idea is to dust the stone there. So we are using the dusting mode that permits a range of 15 to 20 hertz frequency and low joule from 0.2 to 0.8 joule. And we are dusting the stone. This stone is rather soft one. The culture was previously sterile. Of course, the patient has taken antibiotics during the operation. Dusting, as usual. We have good deflection. We can start from the periphery even of the stone and go centrally. This is very important to use a pump during the procedure. Of course, taking care of not to increase the intrarenal pressures, but it's important because it facilitates the view very much, and you can go quicker. As soon as we finish this step and we believe that the fragments are small enough to be retracted, the next phase will start with basketing. We will see in a few minutes. But of course, we try to make it as tiny as possible. We have finished, according to our opinion, the dusting. Again, a second look, maybe here, a little bit more. Then we retract the laser fiber and we insert the basket. We used, in this case, two types of baskets. Nitinol basket, one tipless nitinol basket, standard 1.9 French, that facilitates the flow through the 3.6 French lumen of the instrument, as we can see here. But we also used another basket, another nitinol basket, with a grasping capacity from BART that gives the possibility to do some articulation movements in the kidney. So as you will see a little bit later, this type of basket gives the opportunity to take some stones out where you cannot see them very well in an articulation mode and movement. The dimension from BART, and the other one is the skylight. This is the articulation basket, grasper actually. Despite the fact that this is a little bit thicker, 2.4, the deflection of the scope is not very much affected. So it can still reach the place where the stone was. Like this. And meticulously and slowly, all the pieces are taken away. We again flush as we remove fragments to better see and be sure that we do not let something behind that can be clinically relevant later. is actually a standard procedure, as we all know, I think.
I would like to ask you, if you have a stuck stone and a piece, you can't have access in a piece. What do you prefer as complementary? Shortwave lithotripsy, PCNL, or leave it in this?
Shall we come back to just a little bit go on, and I will answer this question, Mr. Chairman. So after finishing this, we have taken everything out according to our judgment. We do a renoscopy, and we visually check again everything, that the calyces are clean. We go to the place where the stone was with some contrast again. The calyx is free, both visually and in the X-ray. And I would like to stress this point because I think it's important in every RIRS. After finishing the procedure, the last step is to retract both the instrument and under direct visual, a direct vision to check the ureteral walls for potential traumas during the insertion. So we retract both the access sheath and the scope, and we check the walls. In this case, we see that the wall is intact and there is no problem. And after that, we always put a WJ stent, as you will see, over the safety guide wire. The procedure is over, and the patient is discharged the next day, and we keep the WJ for 5 days, as you will see later. So coming back to your question, if it is stuck in the sheath, for example.
In the sheath, in the calyces. There is no floating the stone there. You dust it third quarter of the stone and remain a piece that you can't have access with the flexible. What do you prefer to complete? You prefer to have a complementary shockwave lithotripsy, or leave it in the place?
No, it depends on the place. If I predict based on the angles that this will be clinically relevant, I will come back with SWL. But actually, with these scopes nowadays, almost every place in the kidney is accessible. I think, in my humble opinion, I haven't seen that. The problem is if you have stuck it in the sheath. If it is in the sheath, you cannot take it out. You can either take the sheath out with the stone inside and leave the safety guide wire in, or you can push it back and go further to break it in the renal pelvis, for example. This happens.